Thank you. Good morning, dear audience. It is my honor to present you the 9-month progress report of my PhD journey, the application of enhanced recovery after surgery protocol to improve patient outcomes after surgeries. Allow me to introduce myself. I'm András Czébely-Lénárt. I'm a 4th-year medical doctor at Semmelweis University, Department of Obstetrics and Gynecology, and a first-year PhD student at Center for Translational Medicine. With our research team, our vision is that every patient will get the best evidence-based care before and after surgeries. And to achieve this, our mission is to integrate the newest evidence-based routines into clinical practice. Currently, we are working on 2 different projects, which I would like to elaborate for you. The first one is investigating the patient outcomes in bowel resection surgeries with and without mechanical and oral antibiotic preparation. This is a systematic review and network meta-analysis. Infectious complications are common after colorectal surgery. The incidence of surgical site infection is between 5 to 23%, and anastomosis leakage is between 2 to 10% of the cases, respectively. There are 2 types of bowel preparation aiming to reduce complication rates. The first one is mechanical bowel preparation, which means drinking large amount of special laxative to expel fecal matter from the bowel. And the second one is administration of oral antibiotics prior to the surgery to reduce bacterial load. Finding the proper preparation technique is crucial to reduce complication rates. However, there is not a widely accepted protocol for standard of care. Institutes use conventional, sometimes old-fashioned routines instead of up-to-date evidence. So our aim is to evaluate the optimal bowel preparation method to be used for elective colorectal surgery to minimize complication rates. Our clinical question is, what is the proper combination of mechanical and oral antibiotic bowel preparation to reduce postoperative complication rates in patients undergoing surgeries with bowel resection? We use the PICO framework. The population is surgeries with bowel resection. The intervention groups are mechanical bowel preparation alone, oral antibiotic preparation alone. These 2 combine together, and the control group is no preparation at all. We are focusing on postoperative complication rates, such as surgical site infection and anastomosis leakage as key outcomes. Our hypothesis suggests that combining mechanical and oral antibiotic bowel preparation in preoperative routines will reduce postoperative complication rates in surgeries with bowel resection. We conducted our systematic search in 3 different databases with the search key can be seen, and we ended up with 89 eligible studies after full text selection. Without further ado, let's dive into the results of our study. On our first figure, you can see the odds ratio for surgical site infection based on RCT results. As the reference, we are using no preparation. On the left side, below 1, you can see less surgical site infection than no preparation, and above 1 is more surgical site infection than no preparation. As we can see, mechanical and oral antibiotic bowel preparation used together has the lowest odds ratio, as low as 0.52, with a mathematically and clinically significant difference. And mechanical bowel preparation seems to have no effect compared to no preparation in reducing surgical site infection. Oral antibiotic preparation has a clinically significant reduction, although it's mathematically not significant. But if we look at the patient numbers, we have the fewest patient number in oral antibiotic preparation group. So we performed the sensitivity analysis, and we included observational studies as well, because the bigger the pool is, the stronger the evidence could reach. After the observational study results included, we ended up with 5 times higher patient number. And as you can see, the oral antibiotic preparation group could reach a significant, mathematically and clinically significant reduction in surgical site infection. Looking at the anastomosis leakage results, the odds ratio for anastomosis leakage based on RCT results, we can see that compared to no preparation at all, mechanical and oral bowel preparation shows a significant reduction of anastomosis leakage, and mechanical bowel preparation seems to have no effect on reducing anastomosis leakage inside surgeries. The strength of our study is that it shows a comprehensive picture for all types of bowel preparation. We have the largest patient number compared to other previous meta-analyses. And with sensitivity analysis, we could include observational studies as well. Although we have some limitations, that we could only include few number of RCTs comparing combined preparation versus antibiotic preparation alone. And we could only find few information about surgery type and resection site specific complication rates. Our study shows that mechanical and oral antibiotic preparation used together is the best approach to reduce complication rates, and oral antibiotic preparation alone has promising effects also. Our implication for practice is that combined bowel preparation should be used as a gold standard in every institute. Mechanical bowel preparation should not be alone, but always with oral antibiotics. And if mechanical bowel preparation is somewhat contraindicated, oral antibiotics should be used alone. Our implication for research is that we need more research for the efficacy for oral antibiotic preparation alone, and we need more detailed reporting about complication rates specific for resection site, so we can differ rectal and colon resection site specific outcomes. Currently, we have started the manuscript writing, and allow me to move on to my second project, which is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. This is a systematic review and meta-analysis. Conventional protocols after bowel resection recommend fasting with administration of just intravenous fluid until full bowel function recovery. However, ERAS protocol suggests early oral feeding as it reduces the length of postoperative ileus and length of stay at the hospital. As we can see, the resolution of ileus and length of stay at the hospital could also be shortened if we use the early feeding method. So our aim is to investigate the advantages of early postoperative oral feeding. Our clinical question, what is the optimal timing for first oral feeding after bowel resection surgeries? We are focusing on bowel resection patients after operation, comparing early oral feeding versus fasting. And we are measuring the time of the resolution of the postoperative ileus and length of stay at the hospital as primary outcomes, and postoperative complication rates as secondary outcomes. Our hypothesis suggests that early oral feeding after bowel resection surgeries will reduce the length of postoperative stay, postoperative ileus, length of stay at the hospital, and complication rates as well. Our clinical implication is to ensure quicker and safe recovery after bowel resection surgeries. For summary, for the first project, we want to submit it by the middle of this summer, and the second project we want to be finished by the end of this year. And for last but not least, a smooth sea doesn't make a skilled sailor. Thank you for your attention.
Thank you very much. Excuse my question, for I'm just a statistician, but I see an enthusiastic surgeon, and this is a gynecology class, section. So do you see any indications or contraindications of your results specifically to gynecology and urology cases?
Well, gynecologic surgeries, a lot of time includes bowel resections as well. So we have we can use these results in everyday routine.
Oh,
And urologist as well. Urologist as well.
thank you very much.
I have a question as well regarding your first topic. What kind of antibiotics have you investigated? And do you have any microbiological data as well?
Yeah, there is not a widely accepted protocol for antibiotic use. In every different articles, we found different types of antibiotic dosage and types and methods or times they applied. So I can't say a specific antibiotic because it's very diverse. And sorry, what was the second part of the question? Microbiology. Yes, there are some RCTs examining microbiological results, but we didn't include them since they didn't contain the proper outcomes for us, which we could examine.
Thank you very much.
Thank you.
Congratulations for beautiful presentation.
Thank you.
I got one question. In your practice, in your clinical practice, do you already use the oral antibiotics?
Yes, most of the cases we use them, yes, combined with mechanical bowel preparation.
And which one? In your current data, did you see any preference for certain type of the antibiotics compared to others?
I think most of the times we use metronidazole because it's perfect for the bowels.
Thank you.
I also have one more question. So one of your outcomes was the anastomotic leakage. What do you think, how can bowel preparation reduce the anastomotic leakage?
Well, anastomosis leakage, if I understand well, it starts from surgical site infection. Surgical site infection reduces healing of the anastomosis and increases septical complications of the patient. So anastomosis leakage can occur when there is a inflammation of that part of the bowel. And since we use antibiotics to reduce bacterial load, we can reduce septical complications, and with expelling fecal matter from the bowel, we could also reduce the septical complications with those two methods combined together, and that's how we aiming to reduce anastomosis leakage.
All right. And for the second project, what do you think, what's the optimal time of free feeding after bowel surgeries?
Well, the newest protocol suggests that after 8 hours, we can administrate liquid, per-os liquid consumption, and after the day of the surgery in the morning, we can administrate normal food for the patient.
All right, thank you.
Thank you very much.
I have also a question about your numbers, because you showed us in your results that mechanical preparation has no clinical effect on the infections or other complication. However, if you use combined mechanical and oral preparation, then you have better effect than only oral preparation. What do you think? What is the potentiating effect?
The potentiating effect could lie in mechanical preparation is a laxative, so it washes out the bowel matter. So I think oral antibiotics can reach further if we use it together with laxatives, because it goes through the full bowel length. So that's why I think that's where the solution lies. So laxatives help the oral antibiotics reach the end of the bowel sections. However, if we just use oral antibiotics, bowel the containment of the bowel expel after, I don't know, 3 days, 2 days normally. And these laxatives help to reach the end of the bowel segment faster.
Great, thank you.